What?
The password. No. Good morning again. Today we're going to get highlights about cell wall synthesis after we had in the previous lecture the principles of using the antimicrobes. You've been exposed to many terms that we use frequently when we deal with antimicrobials. So today we're going to get one of the important groups that the members of the subclasses of these groups are extensively used in clinical practice. They act by inhibiting the cell wall synthesis. So we're going to review, importantly, before we do that, we're going to review the bacterial cell wall. And we're going to identify antibiotics that exert antimicrobial effect by different actions on the cell wall itself. And we're going to review the beta-lactam antibiotics and subtypes of the beta-lactams besides the glycopeptides, which are represented by two medications, vancomycin and teicoplanin. And we're going to give highlights about some specific agents among the beta-lactams and the glycopeptides. So in your microbiology sessions, you had the structure of you received information about the structure or of the microbes. That will make this presentation more easier by knowing that the bacterial cell wall is a vital structure for the bacterial cell. That's for two reasons. First, it gives the bacteria its shape and the integrity of the bacterial cell. Also, it inhibits the bacteria from the osmotic because those microbes actually they easily move or from an environment to another environment. Like even when within the liquids environments, like when they move from a high pH to lower pH environment, from salty water to formal or non-salty water, all of these could affect the osmotic pressure around the cell, the bacterial cell itself. So the change in the osmolarity around in the environment or that surrounds the bacteria, because the cell membrane actually is water could freely pass through the cell membrane of the bacteria. So with the change of the osmolarity or the environment surrounding the bacterial cell, that might if the environment was hypoosmolar, because the bacterial cell is hyperosmolar, so most of the fluid might be shifted to go inside the cell wall, and that will lead to the swelling of the bacterial cell and is burst at the end. So the cell wall will maintain this the passage of the water from the outside to inside and vice versa, depend on the surrounding environment of the bacteria. That's how the bacterial cell wall is, how it consists from peptide glycans. And this peptide glycan is actually a sugar or a derivative of glucose bound to a protein, which is a peptide. In reality, this is a tetrapeptide because it consists from 4 amino acids. And these are the amino acids that links links each row of the peptide glycan. The peptide glycan actually each row consists of alternating peptide glycan molecule, which is it could be the acetylglucosamine, what we call it the NAG, or the acetyl numeric acid, what we call it the NAM. So we in each row of peptide glycan we have NAG, then with the one NAM, and that will continue till the end of the chain. And there's a cross links between each row and row, and that's which is formed by what I just endorsed a while ago, which is the tetrapeptide chain. Importantly, the D-alanine, which is actually you're not going to find it in the advanced microorganisms. And this is a shift or a change that was formed by the bacteria to prevent its lysis by the peptidase that found in the host, like for the host or the more advanced microorganism. Always it's the isomer, you know, because as with the molecule, you're going to view the molecule on the mirror, so it will be the position of the like, let's say, of the external atoms will be shifted to the other side, and that will prevent the enzymes to break down the protein or to be fitted well between the two atoms when if this was the ligand of the enzyme. Now, so this protein will be cross-linking the rows of the peptidoglycan, and here, which most of our antimicrobials that act on the cell wall, they act on breaking down this cross-links between the peptidoglycan itself. It's it's rarely going to find an antimicrobial that act on the cleaving the peptidoglycan itself. Most of them will act on this cross-links between the rows of the peptidoglycan. And this maybe this illustration will make it more clear for you. So so this is the cell wall of the gram-positive bacteria, while you're going to find it as a thick, multiple rows of peptidoglycan, and the antimicrobials that kills the gram-positive will be acting on cleaving or breaking down this cross-links between the peptidoglycan rows. Now, on the other hand, the gram-negative bacteria, as you had in your microbiology labs, the peptidoglycan cell wall is a bit thinner than compared to the gram-positive, and it's the cell envelope, which collaboratively contain the cell membranes, which, because we have two membranes actually in the gram-negative bacteria, the internal one, which is, we call it the cytoplasmic membrane, then followed with the peptidoglycan. Then above that, you're going to find the external cell membrane, which contain a lipopolysaccharide chains, and these chains actually, they are responsible of the inflammatory process that we as hosts that we develop when the bacterial multiplication is undertaken, and many of these lipopolysaccharides get expelled in the bloodstream, and hence that might elect inflammatory process. And that's and this thickness actually of the cell wall gives the distinctive feature or the color of the gram stain when it's get applied on the gram-positive side. So that's why, because of the thickness and it's being exposed to the dye, that when apply when the laboratory takes they apply the gram stain, it will give you this blue distinctive feature like what we see here in this figure. On the other hand, the pink appearing microorganism or bacteria, so those are the gram negative, and because the dye doesn't penetrate well, so because of the external cell membrane, so it's difficult for the dye to pass through the peptidoglycan. Besides, it's also thin in its structure. Now, the beta-lactams, actually, we have 4 main groups of beta-lactams. We have the penicillins, we have the cephalosporins, the carbapenems, and lastly, the monobactams. And as we had in the previous presentation about some highlights about the beta-lactam and the important or the active moiety of the molecules, you're going to find this beta-lactam ring shared between all the beta-lactams. So this is the active moiety where that exert the antibacterial effect. And also it's the site where many of the bacterial enzymes that it will cleave this beta-lactam ring, so it will render the antimicrobial inactive. So the whole issue about, or the story of the beta-lactam activity lies surrounding this four-membered lactam ring. Now we have four subtypes of the penicillins and five subtypes of the cephalosporins. And regarding the cephalosporins, they are classified to generations, depend on the time of discovery or the introduction of those cephalosporins to clinical practice. So you get, so from here, you know that now that's the first generation, means that those are the first cephalosporins introduced to clinical practice, while the fifth generation is the most recent cephalosporins that we're using in our hands. So how they exert their activity? So these agents, so that's the NAM and the NAG alternating. This is the cross section or the tetrapeptide. And you're going to observe here that there are actually 5 amino acids. Now, what happens? This transpeptidase enzyme, it will kick one of the amino acids during its process of linking the two rows of the peptidoglycan. So one amino acid will be kicked out, and this kick of the one of the amino acids will help in ligating of the two chains of the amino acids. And that's what we call it, the transpeptidase, or we call it the penicillin binding site. So those are the penicillin binding sites. They are actually amino enzymes that links the two chains of a potato or the two rows of peptidoglycans. So what happens that the beta-lactam ring, which is the active moiety, it will be internalized within the penicillin binding protein or the transpeptidase of the bacteria, and it covalently binds with the transpeptidase. So that will render or paralyze totally this enzyme. So accordingly, with the stop of this important or vital enzyme for the cell wall formation, the cell wall will be destroyed, and that will allow the leak of many of the liquids or any sounding liquids in the liquids in the environment. So it will leak to inside the cell, or that will help forming a large pores in the cell envelope, and that will allow many of the vital content of the cytoplasm will be leaking out. So, and that will kill the bacterial cell at the end. Now, the beta-lactams, actually, they are the most used antimicrobial agents in that constitute around 65% of the prescribed antimicrobials in the United States. They are from the beta-lactams. And cephalosporins, among the whole beta-lactams, 50% of the beta-lactams that are prescribed, they are actually cephalosporins. The advantage of those agents, actually, they are very effective in treating bacterial infections, and at the same time, they are safe. And that's why they are very appealing for clinicians when it comes to treating bacterial infections. The most important toxicity or complication of their use is their association with allergic reactions. So, we are repeating the same what we had in the previous lecture, that like penicillins or around the incidence of penicillin allergies around 10% in the population. Now, if you're going to look to the ability to elect allergic reactions among the beta-lactams, penicillins come at the highest rank or the spectrum of the beta-lactams, followed with the cephalosporins. Then those two agents actually, or the two groups of the beta-lactams, they are the highest. Then far away or more, you're going to find them, the carbapenems. They're lower in their ability to induce allergic reactions as compared to the cephalosporins and penicillins. And the least are the monobactams. Now, so let me ask this question. If a patient who's allergic to penicillin, who require gram-negative coverage, what agent from the beta-lactam could be provided safely? Yes, exactly, the monobactam. So, and that's why the monobactams, actually, they are held in the hospitals formularies. Just their agents could be provided for patients who are known with penicillin allergy. So in those type of patients, even with severe type of documented allergy, monobactams could be delivered safely for those patients. But again, as we received in the previous lecture, that patients who had mild allergy to penicillins might receive cephalosporin. That's very important to take the history from the patient. And you know, what's the incidence or the percentage that the patient might develop a cross reaction between the cephalosporins and the penicillins? Yes, please. It's around 10%, yes. So all of these agents, the beta-lactams, actually, they are bactericidal in their mode of killing of the bacteria. And the problem that might hamper the treatment using the beta-lactams is the developing of resistance. One of the important modes of resistance is forming a beta-lactamase that will destroy the beta-lactam ring. And some of the beta-lactams, actually, they're more resistant compared to other agents, like the carbapenems, and that gives the carbapenems their uniqueness and their broad spectrum of activity, because they actually are stable against many of those beta-lactamases. Nowadays, we have what we call extended spectrum beta-lactamases. Now, the bacteria, because we are using those antibiotics more frequently, the bacteria actually responded by forming new generations of the beta-lactamases, which are able even to cleave the carbapenem ring, the carbapenem lactone ring. And that what we call them the extended spectrum beta-lactamases, or the ESBLs. So the ESBLs, actually, they are Enterobacteriaceae that carries genes that promote the release of extended spectrum beta-lactamases, which are capable to cleave the lactone ring in all the beta-lactams. Now, initially, amoxicillin, with the increased incidence of resistance or the release of the beta-lactamases in the previous century, scientists were able to produce or to provide the amoxicillin with a shield. That's what we call the clavulanic acid. Clavulanic acid is a substance, I think this is not new for you because we had this in the previous session. It's a substance that gets added or combined with the beta-lactam just to prevent, or it will bind first with the surrounding beta-lactamases, so that will give the space for the beta-lactam to work. And one of the important example is clavulanic acid bound to amoxicillin, which yields augmentin. Okay, I don't want to, I'm not asking you to know the beta-lactamase subclass, just only for your information. Maybe you need that in the future or the near future. So I wanted to know from this slide, okay, only the clavulanic acid with amoxicillin, because the emails I received regarding the examples. Let's forget about the unison. Okay, if we are going to get an example of a beta-lactam with beta-lactamase, so it will be clavulanic acid with amoxicillin. Definitely, you need to know tazobactam, which is a new it's new. It's more newer than the clavulanic acid, but it's not very new. Now it's in clinical practice is for more than 30 years. It's going to get combined with piperacillin, which yields an antibiotic called tazocin. Also, there's a new generation. That's the new generation, which is the avibactam. The avibactam is potently binds with the beta-lactamases, and each molecule of avibactam will bind 5 surrounding beta-lactamases, and it's even able to inhibit the ESBL's bacteria. So that's why now we have in our hands, this is among the most important weapons that was approved by the FDA and in the EMA just 5 years back in 2015. So that's an antibiotic that tried now to help many of the patients who develop, who harbor MDR or XDR bacteria by its ability to inhibit all the beta-lactamase, many of the beta-lactamase families. Again, you're not required to know this type of families, okay? You need to know only the beta-lactamase inhibitor and the combined antimicrobial. Now, the natural penicillin, like benzyl penicillin, which was discovered by Fleming, in 1928, and it's effective against Streptococcus pyogenes, which is group A strep, and Streptococcus viridans, which is among the normal flora in the oropharynx, and it might actually, if the viridans had an access to the heart, like during the tooth extraction, that it might cause endocarditis. Penicillin is very efficient agent, still used clinically up to now, treating endocarditis caused by viridans. Also, it's effective against Streptococcus faecalis, which is what we call them the Enterococci, Enterococcus faecalis and facial. Those what we call them group D Streptococci, or we can call them the Enterococci. And it's effective also against Neisseria gonorrhea. And actually, the gonorrhea, the discovery of this antimicrobials or the penicillin, more specifically, saved the lives of many of those patients where gonorrhea at that time in the previous century was a lethal sexual transmitted disease. Penicillin is ineffective against most of the gram-negative rods and the MRSA, methicillin-resistant Staphylococcus aureus. Yes. And those are the indications where penicillin could be nowadays, where it is used for the treatment for necrotizing fasciitis, which is caused mostly by strep, endocarditis in combination with aminoglycosides. Always you need to, when you're treating endocarditis, need to combine penicillin with aminoglycosides, or for treatment of syphilis or rheumatic fever. Now then, more advanced group was introduced, the anti-Staphylococcus aureus penicillins, which are considered narrow spectrum antimicrobials because they only tackle the staph. These agents, they could be used for treatment of cellulitis and other skin infections. They are ineffective against the methicillin, methicillin is also a member of this group. So methicillin, napcillin, oxacillin, all of these group belongs to one single group, which is the anti-staph group. So, and by the notion of knowing that this staph is not effective against the methicillin, that means that it will not be effective against all this, the penicillins in this group. Also, it covered the streptococcal, similar to penicillin, but they're not active against the enterococci. Also, they're ineffective against Bacteroides fragilis, which is anaerobic bacteria. Besides, they are also able to inhibit the growth of gram-negative aerobic bacteria. They are short in their half-lives, and that's why they need to be dosed very frequently, every 6 hours or even every 4 hours. And importantly, or very distinguished feature of the napcillin, that is, it's among the hepatically eliminated medications in the whole beta-lactams. We're going to expose only just isolated cases of those agents that are hepatically eliminated. So they could be, napcillin could be dosed fully in patients with renal impairment. The oral preparation of the of those anti-staph includes diclofenac. It's not important. Okay, let us keep this as an example only. Okay, yeah, just stick to know the napcillin among this subclass of penicillins. The aminopenicillins, we have ampicillin and amoxicillin. and both of these agents is very important to know them. Amoxicillin actually share the same coverage of ampicillin, but it was introduced just to improve the absorption of ampicillin, because ampicillin absorption doesn't reach even 60% when it's received orally. So amoxicillin was introduced to improve this by the bioavailability of ampicillin. The good thing in ampicillin, when it's given IV, it could penetrate well to the CSF, especially in the inflamed meningitis. And that's why it's among the agents that could be used in neonatal meningitis. Again, they are short-lived in the bloodstream, and that's why you need to dose the ampicillin frequently. They are active against, again, enterococci in combination with aminoglycosides, like the same thing like when we use penicillin. When endocarditis is treated by penicillins or aminopenicillins, need to be combined with aminoglycosides. Also, they are among the of-choice agents for the treatment of patients with who get infected with Group B strep, and it could be given or administered to pregnant females before delivery, for patients who test positive for Group B, because the Group B actually is responsible for developing meningitis to the fetus during their passage through the vagina. So it's very important to make the vagina clear from the Group B during the passage, so that will lower significantly the rate of meningitis in pediatrics. Oh, sorry, in neonates. Also, among they're effective against Listeria monocytogenes, which is also another. It's considered as a normal flora in the lady's vagina. So, but there's no recommendation to cover it actually, or to give it as a prophylactic, not like the Group B. So only neonates who get infected with meningitis, then you need to treat those patients with ampicillin, getting the notion that it covers both the strep Group B and the Listeria monocytogenes. Also, they're effective against some of the Enterobacteriaceae species, and they're not effective against Pseudomonas aeruginosa and the MRSA. شباب اللي ورا والله شويه في النقنج ساوند هذا شويه ترى مو لكم انتم بس for me, sorry for that. It's also effective in treating community acquired infections, and we don't use this agent in hospital setting unless if we had a confirmed cultural sensitivity showing that this agent are sensitive. Otherwise, we don't use them as empirical to treat patients who are hospitalized because they don't cover Pseudomonas and MRSA. The anti-pseudomonal penicillins that include piperacillin alone, it could exert an excellent activity against Pseudomonas species, and adding or fortifying the piperacillin with a beta-lactamase, that will expand its activity against many of the anaerobic bacteria like the Bacteroides fragilis, which is the most abundant microorganism in the colon, and it would cover the methicillin-sensitive Staphylococcus aureus. So this agent, the piperacillin, is very efficient in treating hospital-acquired infections. And the piperacillin tazobactam, it could be introduced to treat even polymicrobial infections like intra-abdominal infections, because it covers most of the spectrum of the microbes, gram-negative, including Pseudomonas, gram-positive, including Staphylococcus aureus, and anaerobic bacteria. So it could be used as a single solo agent. On the other hand, this agent cannot be used to treat meningitis because the tazobactam part of the combination cannot pass to the CSF. It's not effective against most of the beta-lactams, except the carbapenems, against the ESBLs, and it's not effective against the MRSA. None of the penicillins, actually, none of the penicillins is effective against MRSA. The most, generally, Tazocin is very safe, but in some cases it could induce interstitial nephritis, which could be reflected as nephrotoxicity. Now, those are the cephalosporins, as we had a while ago. It consists. There are actually 5 subclasses. The first generation, reflected as by cephazolene, it covered the gram-positive cocci very fairly, and covered the methicillin-sensitive staph and some of the strips. While their activity against the Enterobacteriaceae, which are the gram-negative growth, it is a bit minimal. So it's not reliable in treating infections caused by those gram-negative. Now, with the introduction of the second generation, they maintain almost the same coverage against the gram-positive, with expanded activity against the gram-negative. And that time, in the 1960s, their interest was to cover the Haemophilus influenza and the Moxarella catarrh, which can induce upper respiratory tract infection. So ciprofloxacin, which it's one of the agents that are up to now these days gets used to treat community acquired upper respiratory tract infections. Then later on, ceftriaxone was introduced, opening the door for a new set of third generation cephalosporin. The ceftriaxone covered many of the gram-positive cocci, but not as effective as the first and the second generation cephalosporins. These agents, they cover better the Staphylococcus aureus. So if you have staph, it's not a good selection to use ceftriaxone, but it covers well the strep and it covers well Streptococcus pneumonia, which we call them the pneumococci. And that was actually it was appealing choice to cover the pneumococci, especially with the increased resistance of pneumococci observed in the last 3 decades in the previous century. And it also had a more expanded spectrum against the gram-negative, including now the ceftriaxone could cover the Klebsiella pneumonia and some of the E. coli. But again, they don't cover the ESBLs. All the cephalosporins, they don't cover the ESBLs. Then later on, ceftazidime was introduced, which have this distinguished feature of covering Pseudomonas aeruginosa. So from all of these agents, till the third, only ceftazidime is able to cover Pseudomonas aeruginosa. Then after that, with the increased prevalence of Pseudomonas infection, cefepime was introduced, which is the first 4th generation cephalosporins. It covers well the gram-positive cocci. Again, now it retained the same activity against the staph with the cefepime. It covered the methicillin-sensitive Staphylococcus aureus. That ceftriaxone and ceftazidime were not very reliable in treating the MSSA. With expanded activity against the gram-negative, that includes Pseudomonas aeruginosa and Enterobacter coliac. Then recently, we had the 5th generation cephalosporin, which carries a very distinguished feature by its ability to cover most of the gram-positive, including those that are resistant to cephazoline and ciprofloxacin, like the MRSA. So the cephalosporin that covers the MRSA are the 5th generation cephalosporin as reflected with ceftriaxone. So all cephalosporins that are inactive against enterococci, they don't cover Bacteroides fragilis, except cefoxetine. So cefoxetine is a 2nd generation cephalosporin. It's a cefamycin. It's not a real cephalosporin. So, but always it gets inserted in the cephalosporin group. But in reality, it's a cefamycin. It has this ability to cover the anaerobic bacteria. All of these agents they don't cover the MRSA, except ceftriaxone, and they don't cover Listeria monocytogenes. That get covered by the ampicillin, as we had a while ago, and that's why ceftriaxone. One of the reasons why ceftriaxone should not be provided for neonates who develop meningitis. And also they are ineffective against atypical bacteria like mycoplasma. Most of the cephalosporins, actually, they are renally eliminated, except for ceftriaxone, which share a dual excretion mode of elimination of the medication from human bodies. Now, because they cover many of the anaerobic bacteria, but not the Bacteroides, they show this ability to increase the risk of superinfections with Clostridium difficile. Also, because they are time-dependent antimicrobial, now there's a new trend of giving the cephalosporins as a continuous infusion during the day. The patient will be administered one bag of a full dose of cephalosporin, and this will be left to for continuous infusion for the whole period of the therapy. They consider nowadays the backbone of the surgical prophylaxis, especially when it comes to cefazolin and cefoxitin for surgeries that requiring coverage of the anaerobic bacteria, like colorectal surgeries. They might induce a positive Combs test. So if you are doing Combs test to assess hemolytic anemia, you need to consider that the cephalosporin might give a false positive for those patients. Maybe they're not diagnosed with hemolytic anemia, but the test might be flagged positive. Now, ceftriaxone has the ability to bind well with the albumin. It's contraindicated in preterm neonates, and better to be avoided in newborn neonates. And that's because they might do some kernicterus, which is the precipitation of the bilirubin and the basal ganglia of the neonate, and it might lead to some irreversible brain damage. Because actually the affinity of the ceftriaxone to albumin is higher than the bilirubin, and most of those neonates actually they're physiologically they are jaundiced. So as giving ceftriaxone will add more fuel on the fire, and most of the bilirubin will be displaced, and that will be precipitating in many tissues, including the brain. So always need to avoid ceftriaxone use in those papers. So the previous slide was repeated, so that would be the main slide. So and this is an autopsy of a brain, how it looks like when a patient who die from kernicterus. Now, ceftriaxone is a long-acting cephalosporin. It can be administered once daily, and shares that good advantage of dual elimination mode, and effective in treating capsulated bacteria. The capsulated bacteria are pneumococci, Haemophilus influenza, and Neisseria meningitis. So it's one of the perfect choices for treating meningitis. The adverse effect of ceftriaxone, because that this mode of excretion because it's biliary excreted from the liver, so it might induce cholelithiasis or cholestasis, and that would again will increase the propensity to develop cholecystitis. Now, the carbapenems, I want you to know from the carbapenems, the imipenem, cilastatin, and cilastatin is added to imipenem just to prevent its destruction or its renal excretion. Without cilastatin, the imipenem will be secreted in just 10 minutes, and it will be unable to let antibacterial activity. They are effective against the ESBLs and effective against the anaerobes, but not effective against MRSA and one of the nasty bugs that attacks patient life in hospitals, which we call Stenotocomonas maltophilia. All of the carbapenems are renally eliminated, but the problem with the carbapenems actually, they shown to increase the risk of seizure in patients, especially in patients with renal impairment. Initially, imipenem was introduced in clinical practice in high doses. So most of the reported cases actually were reported in the early days of using imipenem. Then after that, imipenem standard dose was reduced from 1 gram every 6 hours to 0.5 grams to every 6 hours daily basis, just to minimize the risk of developing seizure. And so you need to take precaution in patients who are really impaired and patients actually who are presenting with seizure disorder. So patients who are receiving medications that might flag a mark for you before you start giving the patient a carbapenem. If these agents are receiving medications to treat seizure, I mean like anti-epileptic agents, because the threshold of the seizure will be lowered by the carbapenems. Many theories try to explain that. Maybe they actually inhibit or they sorry, the agonists are the GABA receptor, so that will increase the risk of developing seizures. Now, the monobactams reflected with one antimicrobial, we call it the aztreonam. It has excellent activity against most of the gram-negative, including Pseudomonas aeruginosa. Or the aztreonam has no activity against gram-positive cocci or the anaerobes. So always this agent need to be combined if it's going to if you're going to use it empirically, and like what among the patients you're going to use a monobactam empirically. Sorry. No, the carbapenem is better when it comes to the East field. So just in the previous slide, I just talked about it a while ago. If you have a patient who's allergic to penicillins, and you need to cover this patient, okay, with antimicrobial, so you need to get aztreonam combined with an agent that covers well the gram-positive and the anaerobes. You cannot use it alone empirically in hospitalized patients. And that's why many hospitals actually retaining or maintaining aztreonam in their formulary. Just it's an agent that could be used for patients with known history of allergic reaction to penicillins. Now the glycopeptides, which we call them the anti-gram positive agents. They naturally, vancomycin gets extracted from the Streptomyces. It's not from a fungi. Streptomyces orientalis, that was from which the first vancomycin molecule was isolated. It's type of a bacteria among the actinomyces. So Streptomyces is one of the important actinomyces. This is all the side information for you. And you can observe that how you compare this molecule, how it's a large molecule, and from here you could extract its pharmacokinetic profile. Then the first important thing that always vancomycin or teicoplanin need to be given IV, because if you give it orally, it will stay in the gut, it will not be absorbed because of this bulk or the large molecule. Besides, actually, during inflammation, like in meningitis, if the meninges are not inflamed, it's very difficult for vancomycin to pass through the CSF. Now, vancomycin, again, back to those two agents, we have vancomycin, which is mostly globally used glycopeptide. In certain countries in Europe, they use teicoplanin. In King Faisal, we have both of those agents. We have vancomycin. Those who are going to practice King Faisal are going to be exposed to both agents, vancomycin and teicoplanin. The difference is that between those two agents, they share the same antimicrobial coverage, both of them. There's no difference when it comes to its antibacterial activity. Now, for vancomycin, it needs therapeutic drug monitoring, what we call the TDM. It's a way to measure or to dose the patients according to their serum levels. So we all, especially in vancomycin, you're going to see the patients with a result of a serum level of the vancomycin, and we can apply some pharmacokinetic module It's among the jobs that clinical pharmacists they do in hospital. So to tolerate the vancomycin dose to each patient according to his or her pharmacokinetic profile. It's the aim of this drug monitoring is to minimize the toxicity of these agents and to improve the efficacy. Because those agents or the vancomycin is from what we call them agents with narrow therapeutic index. And those agents with narrow therapeutic agents, they are candidates for TDM. Vancomycin it's used in multiple dosing per day. So you're always going to find the patients receiving 2 or 3 doses per day. While on the other hand, the ticoplanin, it doesn't require TDM. It could be dosed on patient's actual weight, how much the patient will be weighing, and that will be according to that the patient will be dosed, and could be given once daily. So this could be one of the advantages of patients who will come to the hospital, take a shot of the medication and go back to home just to continue. And that's why we're, for example, in our hospital, we're maintaining ticoplanin. A patient who developed a MRSA infection, for example, will be treated well during hospital stay with vancomycin. Then if the patient now is stable, we could send the patient home and the patient could access the hospital, come to the DMU, for example, receive 1 shot, and the patient can go back home on a daily basis. Now, how the mechanism of action of the vancomycin? So that's formally is an illustration how the cell wall is actually is formed in the bacteria without the presence of any antimicrobial. And you can see, and this is the DNA that gets picked out during the transcriptase activity. So you will be, so the bacteria will be integrated with 4 molecules only, like the situation over here. So this is especially better than the previous one we had. So we have only 4 molecules after picking out the DNA. Now, the vancomycin, not like that's the site where the beta-lactams act. They act on the peptidase itself that links the 2 side amino acids. The vancomycin acts on different sides. You know, it prevents the removal, the transcriptase or the penicillin binding protein. It will start to get its activity. It's not hindered by the vancomycin. The issue is the vancomycin only will link the 2 molecule of the side chain. The 5th molecule, the amino acid will be there, and because of the vancomycin binding, it will bind the 5th and the 4th amino acid covalently. So the transcriptase, when it comes to kick out the 5th amino acid, cannot. And here, that's how vancomycin exerts its activity. So it inhibits the cell wall in a different side from the beta-lactams. But both of them will be, both groups actually, the glycopeptides and the beta-lactams will be active in the cell wall. The glycopeptides will not inhibit the penicillin binding site, but it will hinder its activity by removal 1 of the amino acids. Is that clear for everyone? Okay. Now, that's the coverage of the gram-positive of the ticoplanin and vancomycin, penicillin-resistant pneumonia, MRSA, coagulase negative Staphylococcus aureus, and even the Clostridium difficile. Let's freeze. Now, the vancomycin is a cornerstone in treating many of the hospital infections, especially when MRSA is of consideration. So always patients with who develop pneumonia in hospital need to be covered with vancomycin. Just empirically, that we're talking about empirical therapy, because we don't know if this patient is harboring MRSA or not. So we need to cover it initially till we get the results of the culture. Then we could de-escalate the therapy. But always, vancomycin needs to be combined with an agent that covers well the gram-negative. For example, anyone can give us an example of vancomycin combined with, like, monobactams is one of the choices. Yes. Other agents more commonly used with a third generation or fourth generation cephalosporin, with a carbapenem, with ceftriaxone, yes, but better for hospitalized patients. You need to cover Pseudomonas, which is not covered by ceftriaxone. So you give the ceftazidime, one of the carbapenems. Moribactam is one of the choices, but it's always repeated for patients with allergic reaction. And also, it's a definitive treatment for any MRSA infections. If there's MRSA, the first choice that pop up to clinicians is vancomycin. It could be given orally to treat C. diff, Clostridium difficile, because it's not absorbed, so it will stay in the colon lumen in very high concentrations because it's not absorbed, so it will retain. It's the same dose that you're giving orally. It will stay in the colon, and that will help in eradicating Clostridium difficile. Also, it could be used in treating mild infection with gram-positive if the patient is allergic to penicillins, and that's why vancomycin could be used in a surgical prophylaxis for patients who's allergic to penicillins, especially those patients with severe allergy. So it could be replaced with vancomycin. Recently, the resistance developing against vancomycin in the last 2 decades. The first case actually was isolated, I believe, in 1988. Then after that, it gets spread, and we call this most of the bacteria that resist vancomycin, they are enterococci, and we call them VREs, vancomycin-resistant enterococci. And the mode of change or the resistance is a change in the binding site of the vancomycin at the level of the 4th and the 5th amino acid. The 5th amino acid actually will be changed from D-alanine to another amino acid. So the vancomycin conformational binding or the legend of vancomycin cannot fit to the 5th amino acid, so it will be rendered inactive. Now, that's what we call the Mississippi month. It's a well-known, especially those who live in the States, they know the Mississippi month is a type of a dessert that's with a brown color. And initially, vancomycin, when it was introduced, shared the same color of the Mississippi month. It was brown, and that because to many impurities. And for that, vancomycin had initially in the 1950s this bad repetition because of the association with nephrotoxicity and ototoxicity. Now, by the improvement in the purification techniques, that's now with the white color vancomycin that what we have in clinical practice nowadays. Now the powder is very crystal clear. It improved well many of the toxicities of vancomycin. So initially, vancomycin was very toxic because of the impurities, and by the improved purification techniques, again, the rate of nephrotoxicity, especially nephrotoxicity, attenuated significantly compared to the literature that was published in the 1960s and 70s. Now, it requires therapeutic drug monitoring, and as I said, what's the aim of the therapeutic drug monitoring? And most of the nephrotoxicity cases, they develop when the vancomycin levels goes higher than 20 milligrams per liter. Don't need to memorize any numbers here, so just for your information. Now, the red man syndrome, that's what we previously was labeled as red neck syndrome, because some complaints in North America at that time, they changed, rephrased the name to red man syndrome. So the incidence of developing red man syndrome is actually it's a redness that takes a butterfly shape redness or at the back, very distinguished. It starts from the neck in the back. It's very rare to see it in the lower trunk. Mostly it's in the upper trunk. And it's not allergic reaction of vancomycin. It's more related to the rapid infusion of vancomycin. So developing such adverse effect is not an indication to stop or to label patient allergic to vancomycin. So the solution is to prolong the infusion rate of vancomycin And the pathophysiology behind this is the degranulation, the rapid infusion of vancomycin, because it's really very large. So it will be sensed immediately by the mast cells that carry the histamine, and it will expel massive amount of histamine in the bloodstream, and hence that will and that's how it manifests. So again, it's not an allergic reaction. And so the management of those patients just continue therapy, but you need to prolong vancomycin infusion rate from its formal 1 hour to, let's say, 2 hours. And you might provide some pre-medication to the patients who receive vancomycin in form of diphenhydramine, which is one of the famous antihistamine agents. Okay, thank you very much. And for any questions? طيب شكرا لكم. بالنسبة لازم موجود على الديسكتوب. اوكي طيب شكرا جزيلا.
One of the slides, there was an FTDX like